everybody. This is Dr. Brett Talley Daniel, MD, and I'm a headache doctor and neurologist, and today I'm talking on migraine and sex. I'm going to start off with a comment from really one of the first physicians involved in writing about this type of migraine, Dr. James W. Lance from Sydney, Australia. He made the following comment in 1974 in an article in the Proceedings of the Australian Association of Neurologists entitled, open quote, "Headaches Occurring During Sexual Activity," period. Since various foods and wines are often incriminated as sources of headache, it seemed to be only a matter of time before sexual intercourse was added to the list of pleasurable activities which may be responsible for headache, the most common of all killjoys, period, end of quotes. Well, I had a chance one time in Dallas at the medical school to hear Dr. Lance talk. He's a famous headache guy. Related questions. What's the description of primary headache associated with sexual activity? Well, it's a sudden, severe, oftentimes explosive headache that occurs at orgasm, and it can be a very alarming symptom. The term sudden may need further explanation. These headaches come on in seconds, like a flash, like a bolt from the blue, like I was hit on the head with a hammer. The International Classification of Headaches, version 3, calls this orgasmic headache. And they describe a dull, aching variety of headache, which is pre-orgasmic, also occurs usually during sexual activity, but before orgasm. And the pain of this type is associated in the occipital, that's the back part of the head and neck, and associated with awareness of neck and our jaw muscle contractions. This dull type may be abated by cessation of sexual activity. Normal spinal fluid examination and brain imaging are required for the diagnosis of pre-orgasmic headache or orgasmic headache. And Dr. Diamond et al. Noted that this syndrome has been termed, and he lists some names from an article: benign coital cephalgia, coital headache, benign masturbatory cephalgia, orgasmic headache, intercourse headache, and headache related to sexual activity. Lute stated about this type of headache, quote, "They all have a rather unpredictable clinical course. They may occur suddenly, continue for some time, and then end abruptly." Ostergaard put the syndrome in a more optimistic perspective when he stated, "Frequently, however, it is a troublesome but rather benign kind of headache in which no serious underlying condition can be found." The phrase, "not tonight, I have a headache," is a common humorous cliché reflecting socially assumed gender differences in sex drive and the perceived role of women regarding controlling and sometimes avoiding sexual activity, which exists in our modern culture. The phrase, reportedly attributed to Napoleon Bonaparte's wife, is stereotypically used by wives as an excuse to avoid sexual relations with their husbands. Since migraine is a common disabling condition, the medical justification of avoiding sexual relations during a bad headache is certainly justified. However, Couch and Bears reported in 1987 that some individuals had noted relief from migraine headache with sexual activity and orgasm. These researchers noted that, quote, "Traditionally it has been thought that sexual activity makes migraine worse." They reported 31 patients, 29 females, and 2 males who had intermittent migraine. When queried regarding engagement in sexual activity during a migraine headache, 7 women had never attempted sexual relations during a migraine headache. 12 indicated that it did not affect their headaches either way, and 3 women felt it made them worse. 7 women indicated their headaches improved with sexual activity, 2 experienced complete relief, 3 noted significant relief, and 2 noted slight improvements. The 2 males reported that they had never attempted sexual activity during a migraine. What does the International Classification of Headache Disorder 3, which is the Bible for headaches, say about primary headaches associated with sexual activity? They list some previously used terms called benign sex headache, benign vascular sexual headache, coital cephalgia, coital headache, intercourse headache, orgasmic cephalgia, orgasmic headache, and sexual headache. It's also been called postural headache occurring after coitus, and that should be coded in a different way as headache attributed to spontaneous intracranial hypotension because it's most likely due to a spinal fluid leak. Headache precipitated by sexual activity, usually starting as a dull bilateral ache as sexual excitement increases and suddenly become intense at orgasm in the absence of any intracranial disorder. So the diagnostic criteria are at least 2 episodes of pain in the head and or the neck fulfilling the following criteria. The headache should be brought on by and occurring only during sexual activity. It should have either or both of the following: increasing in intensity with increasing sexual excitement, abrupt explosive intensity just before or with orgasm, lasting from 1 minute to 24 hours with severe intensity and or up to 72 hours with mild intensity. It's not accounted for by another type of headache. Primary headache associated with sexual activity is not associated with disturbance of consciousness, vomiting, or visual, sensory, or motor symptoms, whereas symptomatic sexual headache may be. On the first onset of a headache with sexual activity, it's mandatory to exclude subarachnoid hemorrhage, and extracranial arterial dissection, and reversible cerebral vasoconstriction syndrome, abbreviated as RCVS. Multiple headaches, which are explosive during sexual activity, should be considered as headache attributed to reversible cerebral vasoconstriction syndrome until proven otherwise by angiographic studies, including conventional magnetic resonance or computed tomography, angiography, or transcranial Doppler ultrasonography. Of note, vasoconstrictions may not be observed in the early stages of RCVS, therefore follow-up studies may be needed. All right, 2 subtypes, that's called preorganic headache and orgasmic headache, were included in ICD-H1 and 2, but clinical studies have since been unable to distinguish these. Therefore, primary headache associated with sexual headache is now regarded as a single entity with variable presentation. Recent studies have shown that up to 40% of all cases run a chronic course over more than a year. Some patients experience only one attack of primary headache associated with sexual activity during their lives, and they should be diagnosed as probable primary headache associated with sexual activity. So you have to have 2 attacks. For further research of this headache type, it's recommended to include only patients with at least 2 attacks. So 1 doesn't do it. Epidemiological research has further shown that 4.3 primary headaches associated with sexual activity can occur at any sexually active age, is more prevalent in males than in females. Ratios range from 1.2 to 1 and 3 to 1. It occurs independently of the type of sexual activities, is not accompanied by autonomic or vegetative symptoms in most cases, is bilateral in 2/3 and unilateral in 1/3 of cases, and is diffuse or accipitally located in 80% of cases. Attack frequency of 4.3 primary headaches associated with sexual activity should always be related to the frequency of sexual activity. What are other featured primary headaches associated with sexual activity? The first occurrence of headache associated with sexual activity requires thorough neurologic examination, CT or MRI scan and spinal fluid exam to rule out serious problems such as subarachnoid hemorrhage secondary to aneurysmal or arteriovenous malformation rupture or arterial dissection. Subarachnoid hemorrhage has been reported to occur during intercourse in from 3.8 to 12%, depending on who you read that, and another one is 4.1% in AV malformations. Other organic considerations include intracerebral hemorrhage, cerebral venous thrombosis, unruptured vascular malformation, which is predominantly aneurysm, CNS angiitis, reversible benign CNS angiopathy, pituitary apoplexy, colloid cyst of the 3rd ventricle, CSF hypotension, acute sinusitis, especially with barotrauma, pheochromocytoma, Arnold-Chiari malformation, and posterior fossa tumors. Well, what's the relationship to other headache types and exertion? The diagnosis of either primary exertional headache, that is headache brought on by exercise, such as weightlifting, or migraine is reported in about half of the cases. Can headaches like this be related to physical exertion? Well, Hippocrates certainly thought so. He wrote 4 centuries before Christ, quote, "One should be able to recognize those who have headaches from gymnastic exercises or running or walking or hunting or any other reasonable labor or from immoderate venery." And the phrase venery refers to excessive sexual activity. Silbert found that 18 of 45 patients with sex-related headache had also experienced headaches on exertion. Ostergaard et al. In 1992 reported in the British Medical Journal on 32 patients collected through 1978 through 1991 in an article entitled, quote, "Natural Course of Benign Coital Headache." He followed his patients for 6 months to 14 years with a median of 6 years. 5 of Ostergaard's 12 patients had migraine without aura, and 7 had tension headache. Fries et al. In 2003 stated, there was a high comorbidity with migraine, 25%, benign exertional headache, 29%, and tension type headache, 45%. Lance stated in an editorial entitled, quote, "When Sex is a Headache," end of quote, in the British Medical Journal in 1991 that such headaches may be well precipitated by an acute pressor response. During orgasm, systolic blood pressure increases by 40 to 100 milliliters of mercury, and diastolic pressure increases by 20 to 50. Quiroz wrote in 2001 that the headaches shared the Valsalva maneuver as a common pathophysiologic mechanism. What's the literature review of primary headache associated with sexual activity? Wolfe described 3 women who suffered sudden, severe pain in the head at the beginning of orgasm, the headache lasting from several minutes to several days. Fisher briefly touched on the subject while discussing headaches caused by cerebral vascular disease. He reported 3 patients who experienced headache during intercourse, 2 of whom had intracranial hemorrhage. Lance describes the evolution of knowledge about the subject. So he was there at the very beginning. There was correspondence in British Medical Journal in 1973, was recently triggered by an answer given in the section, "Any Questions?" to an inquiry headed, quote, "Severe headache accompanying orgasm." The question described a woman of 50 who for the previous few months had experienced a severe gripping pain which seemed to encase her whole head associated with orgasm. It lasted for about 10 minutes, after which she dropped off to sleep. The questioner asked, "Is this a recognized phenomenon?" The printed answer began, "This is not a recognized phenomenon," and included, "It might be wise, therefore, to assume that something is happening during orgasm, which is raising a presently subclinical disorder to a clinically apparent level." So that's 1973, the start of most modern articles on this subject. In response to this, a number of correspondents wrote to mention individual cases of apparently benign coital headaches, and Martin in 1973 described 6 male patients, all of whom were subject to sudden severe headache towards the end of intercourse, commonly bilateral, affecting the back of the head more often than the front, and lasting 10 to 60 minutes. Although more prolonged attacks were recorded, 3 patients had a past history of migraine. All had remained in good health. Martin quoted Kritz, who had reported 25 cases, all male, in the Czechoslovakia Neurologic Journal. Lance mentioned having seen such cases in 1969, and Martin quotes personal communication from Williams in 1970, who called the condition coital cephalgia. Chris, in 1970, reported 51 patients with neurologic complications occurring during sexual intercourse. 24 of Critt's patients had only brief headaches and nothing else, but 4 of his patients had intracranial hemorrhages, and 10 suffered ischemic cerebral events during sexual relations. Chris stated that 8 of his patients avoided intercourse altogether, while another 10 had to become more passive partners. Martin, in 1974, writing in the Irish Journal of Medical Science on, quote, headache during sexual intercourse, coital cephalgia, end quote, presented 6 examples of a benign syndrome of recurrent headache during sexual intercourse. Martin's report of case 1 follows. An engineer, age 42, referred because of migraine, gave an account of other headaches which came on during sexual intercourse. The first occurred 2 weeks after marriage, and was followed by 2 others in the next month. In each instance, the headache came on abruptly at the onset of orgasm. It was at the back of the neck, spreading to the vertex, and was bilateral. On 2 occasions, it lasted for 10 minutes, once for an hour. There was no nausea or vomiting. Restraint in intercourse was, he thought, of prophylactic value. He was an anxious, obsessional man, was unhappy in his occupation. He had felt run down and had been taking a yeast extract tonic. Follow-up. A year later, he still had occasional headache during intercourse. Sometimes this was accompanied by palpitation and tremor of the hands and possibly pallor. Lance, in 1974, reported 7 cases and wrote in his summary, 7 patients who experienced headache immediately preceding or during sexual orgasm are described. No evidence of any structural lesion was obtained on clinical examination or investigation, including cerebral angiography in 4 of the 7 patients. The syndrome appears to be benign in many instances. Case 2 of Lance's 1974 follows. A woman, aged 26, complained of a sudden occipital headache at the time of orgasm on 2 occasions. The headache was intense and gripping in quality, developing instantaneous like an explosion or like a steel spring snapping. It remained severe for 10 minutes or so, then subsided over an hour. She had experienced a similar headache 3 times before, but precipitating factors were not recorded in the history. There was a past history and family history of migraine headache, but these headaches had been frontal in site and different in character. Examination was normal. Her blood pressure was 140/80, and an EEG, bilateral carotid arteriogram, and pneumoencephalogram were normal. Paulson and Clawins in 1974 in an article entitled Benign Orgasmic Cephalgia described a postural headache resembling that of low CSF pressure developing after coitus and likely related to a dural tear during intercourse. The report of case 1 follows. This 32-year-old Army major developed acute suboccipital pain during intercourse and was seen in consultation 1 day later. His severe headache was strictly limited to the times he was in an upright position. Invariably, within 5 minutes after lying prone, the headache subsided. But when he rose again, the headache soon returned and was associated with dizziness and nausea. There was prior history of migraine. Neurologic and general physical exam were normal, as were both the brain scan and EEG. Lumbar puncture was entirely normal, except for a CSF pressure of less than 20 millimeters. Repeat lumbar puncture 1 day later revealed a pressure of 10 millimeters. Bilateral carotid arteriograms were normal. The headache, which continued to occur only in the upright posture, slowly but completely subsided over the next 3 weeks. The author stated that, quote, in our patients, it's possible that a rent in the spinal fluid space occurred or was widened during the physiologic stress of coitus, end quote. They divide their patients into 3 with low special fluid pressure and 11 other patients with benign orgasmic cephalgia. ICD-1 in 1988 had 3 types of primary headaches associated with sexual activity: the dull aching leading up to orgasm type, the explosive at orgasm variety, and headache related to dural tear and CSF drain. ICD-2 dropped the dural tear variety, which is really a symptomatic headache, under the heading primary headache associated with sexual activity, and kept the pre-orgasmic headache and orgasmic headache. Lance, in an article in 1976, described 21 patients, quote, where no organic change can be demonstrated, analogous to benign cough headache and benign exertional headache, end quote. He noted 2 varieties of headache. 1, developing as sexual excitement mounted, had the characteristics of muscle contraction headache. The second, severe throbbing or explosive character occurring at the time of orgasm, was presumably of vascular origin associated with a hyperdynamic circulatory state, end of quote. Lance pointed out that the headaches were similar to those found with exacerbations of pheochromocytoma. Lance, in his review of the British Medical Journal in 1991, quote, entitled, "When Sex is a Headache," end of quote, added the following statement below the title, and I quote, not funny, but usually not serious. In this BMJ editorial, Dr. Lance reinforced the previous statement regarding a benign outcome by Ostergaard. Fortunately, most headaches associated with sexual excitement do not have any sinister cause, and the benign forms have a characteristic pattern that enables diagnosis in most cases. Dr. Lance also stated in his editorial, benign sex headaches have been reported in patients from 18 to 58 years of age, more commonly in men than women, capricious in its appearance. It mysteriously develops on some occasions, but not others, without any obvious change in sexual technique. It more commonly occurs when the subject is tired, under stress, or attempting intercourse for the second or third time in close succession. Sometimes the severe orgasmic headache may be preceded by a dull occipital ache, in which case the subject should desist on that occasion. Fries et al. Wrote in 2003 in Neurology about, quote, headache associated with sexual activity, demography, clinical features, and comorbidities, end quote. They identified 51 patients between 1996 and 2001. The mean age at onset was 39.2 years, with a clear male preponderance of 2.9 to 1. Two age peaks were noted, one between 20 to 24 years old, and the second between 35 and 45. 11 patients had the dull subtype, while 40 had the explosive type. Fries found that there was a high comorbidity with migraine in 25%, benign exertional headache in 29%, and tension-type headache 45%. Fries et al. Wrote a follow-up article in 2007 on, I quote, headache associated with sexual activity, prognosis, and treatment options, end quote. They reported 60 patients between 1996 and 2004 who were followed between 2003 and 2006, at least 12 months after the first interview. On average, the second interview was conducted 35.9 months after the first exam. 37 out of 45 patients had only a single attack and no more. 7 others had at least one further headache at an average of 2.1 months later. Episodic headache with sexual activity occurred in about 3/4, and chronic headache associated with sexual activity in approximately 1/4 of patients. Of 15 patients with chronic attacks on first exam, 7 went into remission, and 5 had continued attacks. 9 out of 10 of their patients got good results with indomethacin, while 15 out of 18 received good results with beta blockers. The incidence of primary headache associated with sexual activity. Well, the incidence of such a headache coming as it does with sexual relations is very difficult to ascertain, as most patients do not usually talk about this. A French neurologic clinic reported in 1980 an incidence of 0.21% of benign headache related to sexual activity among 3,800 patients seen for headache. Kraft in 1979 reported an incidence of 1.3% in a Danish group among 460 neurology patients. Precipitating factors have been listed as fatigue, second or third orgasm during a single tryst, extramarital affairs, or exotic sexual habits may set off these headaches, although Fries et al. Stated in 2005, in fact, the vast majority of patients develop their headaches with their usual partner or during masturbation. The risk does not seem to increase when the partner or setting changes. Contributing factors are chronic hypertension, obesity, poor physical condition, and psychosocial stress. Duration of headache. Ostergaard et al. Stated in 1992, quote, in all patients, the headaches were very intense for 5 to 15 minutes, and in 4 patients, symptoms then disappeared and did not recur. In 22 patients, headaches declined over 1 to 24 hours and recurred at subsequent attempts at sexual intercourse, performed within a period of up to 6 weeks. In 4 patients, this period lasted 3 to 6 months. 13 patients experienced only one headache or one cluster of coital headaches, whereas in 9 men and 4 women, the coital headache pattern reappeared after a headache-free period of up to 10 years. 6 of these patients had more than 3 recurrent clusters. Perez et al. In 2005 found that the duration of pain, quote, varies widely. The median duration of pain was 30 minutes, with most severe pain lasting less than 4 hours. Headache description. Perez et al. In 2003 found 11 patients with the dull type and 40 with the explosive type. He found that, quote, the pain was predominantly bilateral in 67% and diffuse or occipital in 76%. The quality was nearly equally distributed among dull, throbbing, and stabbing. Perez et al. Stated in 2005 in a review article for the journal Practical Neurology that pain is occipital or diffuse in 3/4 of the patients, bilateral in 2/3, and unilateral in 1/3. The quality is dull in about 1/2, throbbing in 1/2, and stabbing in about 1/2 of patients. Sometimes patients could give more than one quality. Associated symptoms. Accompanying symptoms such as nausea and dizziness are rare, but do occur. However, severe or focal neurologic symptoms such as vomiting, decreased level of consciousness, a stiff neck, hemiparesis or hemicentery symptoms, visual changes, a seizure, or severe pain for more than 24 hours are not the features of primary headache associated with sexual activity, and those symptoms require immediate diagnostic workup. Lundberg and Osterman, in an article in Headache in 1974 entitled, quote, the benign and malignant forms of organic cephalgia reported sexual intercourse as precipitating factor of 6 of 50 cases of subarachnoid hemorrhage. Prevention and treatment. Headaches-related to sexual activity may be prevented in some patients by weight loss, an exercise program, a more passive role during sexual relations, variation in posture, limitation of additional sexual activity on the same day, and by medication. Many patients found some good effect for both the dull and explosive types of cessation of headache and onset of headache and deferring relations to another time. Some patients may recognize mild headache before sexual activity begin and then do well by delaying sexual contact until later. Acute therapy migraine drugs have been used before sex relations as preventive, and what's been reported in the neurology literature are indomethacin, 25 to 100 milligrams, given 30 to 60 minutes before sexual activity, and triptans. For frequent occurrence of this headache type, Inderal, propranolol, 60 to 240 milligrams, or Cardizem, Tyzek, which is Dilatazem, 60 milligrams 3 times a day, or long-acting 180 milligrams a day may be tried. It seems reasonable to try other migraine preventive drugs, such as amitriptyline, topiramate, valproic acid, or even one of the new CGRP antibody drugs, such as Ajovy, Emgality, or Aimovig, but there is currently no data on these drugs at this time. Frez found that 2 out of 3 patients using triptans as short-term prophylaxis had a good response on several occasions. They stated, in patients who chose to predict their sexual activity, short-term prophylaxis with oral triptans 30 minutes before sexual activity might be a therapeutic option in those not responsive to or not tolerating indomethacin. So these are my comments on this subject. I have a big blog article about it, and it's also mentioned in my big migraine textbook on Amazon. All the best to all patients who've had these types of headaches and migraine patients. Please click subscribe so we can keep in touch with each other, and I'll see you again on another talk. God bless you.